All right, good afternoon. We are going to get started with today's session on forgetfulness. Is it normal or is it a warning sign? Thank you for joining us today. My name is Drasher. I'll be your host today. I work with the Emerald Crest Memory Care communities in the Twin Cities. We are owned and managed by Cassia, and I'll speak a little bit about that in the next couple slides. But just to share with you briefly about Emerald Crest, we are a memory care specific assisted living. We have 4 locations: Burnsville, Minnetonka, Shakopee, and Victoria. We have actually been doing memory care since 1998, so over 20 years of doing memory care. We were actually one of the first in the metro area who did memory care because it was such a new concept back then. But we specialize in memory care for a couple different reasons. The first being our environment, which you can see right there. We are more of a home setting. We have 12 units to a house. Some of them have 15, but majority of 12. And they are one-level homes. And the common space is the center of the house, and then the rooms actually surround the common space. So the houses were specifically designed for those with dementia, with no long hallways and very easy to navigate. We focus on providing a very structured at day for our residents. You know, as their dementia has increased, it's a little bit harder for them to keep a daily schedule. So we definitely guide them throughout the day with a daily schedule. We have specific programs and activities that are designed for the different stages of dementia. We actually have multiple houses on our campus, and we do stages in those houses. So one house is early stage, one house is middle stage, and one house is late stage. So we're able to really individualize the daily programming for those residents to meet their needs within those stages. We also develop a very tailored care plan with the help of not only our nurses, but also occupational therapists, to really make sure that we're covering both the physical, medical, and the psychosocial needs of our individuals. We train our caregivers on dementia. They really go through quite a bit initially, but then ongoing, which is nice because being a specialist in dementia care, they really need to be the experts as well as our nurses and our OTs. As I said, there's our 4 locations. You can see them there. There are just some very simple maps if you're wondering where exactly we are. A lot of times people are kind of surprised to know where we are because we're in residential care or residential areas and don't stand out. We're not a big building, so we kind of are tucked in there and kind of blend in with the community, which is kind of nice. We are doing virtual tours right now during COVID. So if you are interested in learning more about Emerald Crest, you can set up a personal video tour with Elizabeth, our admissions manager. Her phone number is there. And you can also go to our website and schedule an appointment with her as well. So as I mentioned, we are owned and managed by Cassia. Cassia is a nonprofit Christian-based organization here in Minnesota. We are an affiliation of Augustana Care and Elam Care. The 2 nonprofits did merge a couple years ago, and they created Cassia. The word Cassia means the heart of a servant, and we really do feel that really fulfills our mission, which is fostering fullness of life for older adults in the spirit of Christ's love. So you can see that on the slide there, both our mission and what Cassia means. You can also see on there that we do have a big representation in Minnesota, but we also have some out-of-state services as well in North Dakota, Colorado, Iowa, and Florida. Most of our services are more senior housing options, and we pretty much have every type of senior housing there. But we also have branched out and have services with hospice, home care, pharmacy, medical supply, assistive technologies, and rehabilitation therapies. So with those service providers, we're able to enhance what we have in our housing, but also reach out to the community more. So if you'd like to learn more information about CASIA, feel free to look at the website, casialife.org. We have a lot of communities that I know would love to, again, do a virtual visit with you if you'd like to learn more about that. All right, we're going to move on to our speakers. Jenny has been with us for over 18 years. She is the director of our cognitive care program. She oversees and works with all of the occupational therapists within the 4 locations of Emerald Crest, and then monitors also the needs specifically at the Shakopee location. Sarah is our occupational therapist over at our Burnsville location. She has been there 12 years. So you can see there we have some long-standing experts in the field of dementia there. And I am going to actually let them maybe explain, if Jenny, if you can maybe start off here, and I'm going to unmute you, so hold on one second here. If you can maybe explain, where are you, unmute, your role as an OT and what makes that different at Emerald Crest compared to the other areas where OTs would be.
Sure. Well, good afternoon, everybody. I guess what makes us unique as the occupational therapists at Emerald Crest is most people, when they think of occupational therapy, they think probably more in the rehab setting. So rehabilitating somebody after a stroke or a knee replacement, hip replacement, that's more your kind of traditional occupational therapy and what I think a lot of people in the general public think of. Our role at Emerald Crest is a bit different, where it's more focused on the cognitive needs, the cognitive impairment. So when I think of the OTs at Emerald Crest, I kind of look at it as 4 different areas. I think the biggest thing is our role in cognitive assessment, working with the nursing staff and the care staff there to assess where a person is in their dementia before they even come through the doors, so that we can give give information on what their abilities and what their cognitive needs are, so that they can be independent as possible in our environment and in the correct house to best meet their needs, again, based on the stage of dementia that they're at. Another big part of our role that's a bit different is it's a lot of caregiver education. We work day in with the direct caregivers that are caring for our residents at Emerald Crest in how do you communicate with somebody at this stage of dementia? How do you approach somebody and complete cares with somebody at this stage? So a lot of education of not only the caregivers, but family members as they go through the dementia journey. And a lot of it too is, again, teaching staff how to engage residents through activity, through our cognitive care program that includes specially designed group activities that are appropriate for a person based on their stage of dementia. So I would say those are kind of the main areas, and a lot of working with behaviors too that we often see with dementia, and working with the caregivers on how to anticipate those behaviors, and then once they're there, how do you manage them? So those are like the 3 or 4 main areas, and what makes us much different than your traditional OT that you're probably more familiar with.
Great, thank you, Jenny. Couple just quick little kind of housekeeping areas I should mention here. We have a good number of individuals on this call, and we know there's going to be questions, but what we'd like to do is use the chat room for questions. And if you have any questions as we go through our presentation here, just go ahead and type it in the chat room, and then I'm going to monitor those questions, and as we either get breaks or at the end of our presentation, we will address those with both Jenny and Sarah. So please do that. And then I will be sending an email out to those that are signed up for this handouts, and a link to the recording. So if you do want to view that or share it with anybody, you'll have that as well. And if you are a healthcare provider and need a CEU, I will also share that with you at that same time. So just a quick couple of little reminders here. Oh, and then also please, if you can, keep yourself on mute and no video. It works a lot nicer for the recording if we can keep the videos off and nothing gets blocked. So we appreciate that. So, all right, so let's get started here. I believe we're going to start with Jenny. So go ahead, Jenny. Thank you.
Yeah. So I like to start this presentation with, what's the difference between normal forgetting and dementia? Looking at that poll that Christine had you complete before we started here, it looked like, a good majority of you are listening in today because, either maybe you're concerned about yourself and, cognitive memory changes, or more likely somebody close to you. Maybe you're a caregiver to a spouse, to a parent, whatever it may be. And so it never fails when we give this presentation out in the community. I always have somebody that will come up to me and they're very concerned often. They'll tell me something like, I was getting ready to leave the house today and I forgot my keys. And it took me a while, 5-10 minutes, to kind of retrace my steps. And then they're very nervous, asking me, is this a sign of possible dementia? And I say to them, more than likely not something to get really worried about. That happens to all of us. That's part of normal forgetting. Now, what I might say to that person, if they're not able to retrace their steps and use problem solving skills and, figure out where they last left their keys, then yeah, maybe that would be a bigger concern. Or if you're finding your keys that you had put them in the freezer or the refrigerator, then that might be a concern. So really, let's look at what is normal forgetting and what is dementia. With normal forgetting, it's very sporadic. It maybe happens here and there. It's not a constant daily thing. The big thing with normal forgetting is it often occurs when we're going through times in our life where we're under a lot of stress and fatigue. And I can kind of speak for myself. The example I often use is a couple years ago, I had gotten influenza A. And I remember just how sick I was. And I was at home, of course, and I was trying to take a conference call for work. And I remember hanging up the phone that day and not remembering a word that was said on that conference call. I was sick. I was tired. I wasn't feeling good. My immune system was down. I just was not thinking straight. And I'm sure we can all think in our own experience, our own life, of times where we've been in that situation under a lot of stress, under a lot of fatigue. We're just not thinking clearly. But the difference is once I was able to find out it was the flu, got started on antibiotics, within that 6-7 days, I was back to my baseline. I was thinking clearly. I was back to my baseline thinking skills. With normal forgetting, it does not affect our overall day-to-day functioning. Even under times of stress and fatigue, when we're not maybe as clear, we still can carry out our day-to-day. Most of us can still go to our jobs, complete the functions of our job that we need to. We can take care of the household, take care of the kids. We can still function day to day. Now, the big difference here is if somebody actually has been diagnosed with a type of dementia, it's not just here and there. It's not just under times of stress and fatigue. They are dealing with cognitive impairment, memory loss every single day, from the time they get up in the morning to the time that they go to bed at night. And big difference is it does affect their overall day-to-day functioning. I was working with a man in the clinic many years ago, and he was being seen for cognitive assessment because he was maybe upper 50s, early 60s, and he had been working for a computer programming company all his life, 30 plus years. And he had went to work one day and sat down at his computer monitor, something he did every single day of his life, and he couldn't remember how to turn on the computer monitor to start the computer. And of course, that raised red flags with the folks that worked around him. They brought it to the attention of his supervisor, and then his supervisor then contacted the wife, said that we had concerns with him at the job, um, and being able to complete his job tasks. And then the wife got him in to be evaluated by the doctor, and he was diagnosed with early onset Alzheimer's. And although that might be a severe case, a drastic example, it's a good example of how people that actually do have a diagnosed dementia, it does start to affect their overall day-to-day functioning. You can go to the next slide. Dementia is not a normal part of aging. This is another piece I like to talk about. A lot of times what I will hear from family members, caregivers is, well, my mom or dad is 85 plus years old. Of course, they're not going to remember how to do this. They're not going to remember this or that. And my point here is we have to remember that dementia is not a part of aging. Just because you hit 65 doesn't mean that you're going to get dementia. Now, I don't know how many people have heard of the Delaney sisters, but I like to give this example because I think it's a good one. They have a book out. It's two sisters. It was called Having Our Say. It's a great read if you do enjoy reading. And they lived, I probably don't have the ages right, but I think one maybe lived to be like 104 and another 106. So they lived a long, long life. And up until shortly before their death, they were still both living in their own homes, taking care of their own homes. They were financially taking care of themselves. They were still driving. They had no cognitive impairment whatsoever. They also were both very talented artists, and they would go all over the country to different art shows showing their artwork. So very, very talented, very independent, very, cognitively intact. And they were interviewed shortly before their death, and the gentleman interviewing them had asked, what would you say is the key to a long and healthy, happy life? And they both listed three things right away. They both said, well, one, we exercise daily. So some kind of movement or exercise they did each and every day of their life. The second one, which I don't quite understand this one, but they said every morning they would take a tablespoon of castor oil. And then the third one, which is the kicker, is they both said they never got married. So take it as you may, but I think it's a cute example, but also a very good example of how dementia is not necessarily a normal part of aging. So let's go into then, what is dementia? I often like to ask my audience of that, what is dementia? And a lot of people, first thing they think of, which makes sense, is they'll think of memory loss. They'll think of somebody being confused, somebody not being able to find the right words, which are all correct answers. The way I define it is I define it more in a general term. It's a syndrome that affects an individual's overall thinking skills. It's like an umbrella term for cognitive loss. And really what we see with dementia when it does start with somebody is it really begins with subtle changes at first in more of their ability to complete higher level skills. And what I mean by that with higher level skills is things like their ability to organize their house, their job, manage their finances, driving. A lot of times what I'll hear from family members, especially kids that may not live right by mom and dad or live out of state, they'll come home for the holidays, with the holidays coming up, and they'll be maybe going through mom's checkbook and notice that she's completely forgot to pay this bill or pay that bill, or she hasn't balanced her checkbook in months, or mom was always somebody that was just kept her house very, very neat. And now they come home and they find that the house is very disorganized. piles of paper everywhere. It just wouldn't be how mom or dad would normally keep the house. And even with driving, that's interesting to hear stories on that, because it'll usually start with little minor fender benders. They'll see a dent in mom or dad's fender or back bumper, and the excuse will be, oh, I didn't see the garbage cans at the end of the driveway and I bumped into them. So you'll start to see subtle changes in those type of activities. It never starts with all of a sudden they can't, brush their teeth, comb their hair, dress themselves. That usually, comes into play as they progressed further. The first sign or symptom noticed by others often is memory loss, which makes sense. I mean, if you think about cognitive skills, memory loss is probably the easiest one to notice. If you're talking to your loved one and they're not remembering birthdays of family members that they've always remembered, or special dates such as anniversaries, or not remembering their doctor's appointments, you can see that change versus how do you always notice if someone isn't able to problem solve or make sound decisions. It's not something you might pick up on as quickly as memory loss. Also, by the time they're admitted to, and let's say now they've progressed and their, family members are looking at, admitting them to a place like an assisted living, long-term care facility, a place like Emerald Crest. By that point, they've really progressed to the point where they're probably more in the middle stages of their dementia, where it's not just those subtle changes in higher skills, it's now decreased ability to really consistently and safely complete those daily cares. So the dressing, the grooming, the meals, they need somebody there supervising and assisting with that. Now, I like to show this. It's titled Components of Cognition. I also have called it the Wheel of Cognition, and it's kind of pointing out that point of, dementia is not just memory loss. Again, we see memory, it's the easiest thing to see at first, but if you look at this wheel, look at all of the different cognitive skills that are needed to complete just day-to-day tasks, to function. Somebody that has dementia, all of these areas are being affected, a lot of times at the same time. So you can begin to really see how a person with dementia really struggles each and every day just to do even basic tasks. So it's not just memory, it's they can't focus, they can't attend anymore. They're starting to lose their language, not being able to verbalize their needs. They're not oriented to, date, time, place. That starts initiation. Mom and dad, it's noon and they're still in their pajamas because they don't have any concept of how to initiate their day and what to do first and what to do second. So, I mean, I could go on and on about each of these areas, but the point is just remember it's multiple cognitive skills being impacted. I'm not going to go into detail about this slide. I think this is just a helpful slide to put out there. This is from the Alzheimer's Association, and it's the 10 warning signs, because people always want to know, well, what are the key things that you might see if somebody is showing possible signs of dementia, cognitive loss? And it's things like memory changes that actually disrupt daily life, difficulty completing familiar tasks. And again, I'm not going to go through each one of these, but this can be found if you get on the Alzheimer's Association website. And I would recommend this for anybody that needs more information. They're a great resource to have to kind of help you through it. Now, when somebody is telling me that they're maybe concerned about their own thinking skills or somebody they're caring for, the first thing I'm always going to say is if there's red flags like that, you need to start with your doctor. I'm not a doctor. I can't diagnose dementia, nor can most of you, I'm assuming. So the best thing is to get to your doctor. That may be your family practitioner, neurologist, internist, psychiatrist, so that they can look more closely at what are the red flags, what are you seeing, and what might be causing them. And when you're, meeting with that doctor, try to be as prepared as possible so that you can communicate all of these concerns with them. So even, these are great ideas, having a medical journal. So journaling everything that you're maybe seeing or that's occurring, record, relay observations, experience that you're having, understand, discuss medications and related side effects. Because that's a big thing too, what medications may or may not help with the symptoms, the things that you're seeing. And then most of all, and this would be for anything, ask questions. No question is a dumb question. If you're questioning something, ask it. So when going to the doctor, the reason I recommend it and why it's so important is when an individual shows possible signs of dementia, what should be done. And visiting that doctor is important because they're the ones that can determine what is causing the cognitive changes. And what I mean by that is there's a lot of just general medical conditions that are out there that the signs and symptoms of those medical conditions are very, very similar to somebody that may have a dementia, and this isn't a complete list here. This is just some of the common ones I often see. The difference here is if you go in, you talk to the doctor about your concerns, if they rule that it's one of these conditions, a lot of these conditions can be treated. If it's actually dementia, there is no current treatment for that. Hearing or vision deficits, it's not hard to see that if somebody is hard of hearing or visually impaired, are they going to look more confused? Of course they are. That's why it's so important. I tell my caregivers all the time, when you're getting somebody up and ready for the day, make sure they have their hearing aids in. Make sure that the batteries are actually working, because you're not doing them any favors if one, they're confused and have dementia already, and then they can't hear on top of it, or vision, making sure that their glasses are on and the glasses are actually clean. So hearing and vision deficits, that can make a person look very confused. I'm going to skip down to oxygen deficiency. This is a huge one. If somebody isn't getting adequate oxygen to their brain, they're going to be more confused, right? I once worked with a lady, and she was one of our residents. So yeah, she was diagnosed with dementia, but she also had COPD on top of it. So she was very, very compromised as far as her ability to breathe, her oxygen. And you could tell she was a lot of times not even able to carry on even a simple conversation, wasn't able to track things. Just, you could really tell she was compromised. Well, the doctor ended up finally putting her on 2 liters of oxygen a day. And I will tell you what a difference that made. It was like talking to a completely different person. Was she still forgetful? Would she sometimes still repeat things because of her dementia? Yeah, but you could actually have more detailed conversation. She was more articulate. She was more responsive because she was getting the oxygen she needed. So that's a huge one. I always skip down to medications too. I think about most of our residents that we care for. Some of these people on average can be on medications, 12 or 15 medications a day. And with some of these medications, most of these medications have side effects. And so anytime a medication is added or decreased or DC'd, that can impact their cognitive thinking skills. So it's really important to be watching that. The last one here, infection. I'm sure most of you have heard of urinary tract infections. I will tell you that's probably the #1 infection that we see in our residents. And when somebody has a urinary tract infection, they become very, very confused. And anytime we see a difference in the functioning of even our own residents at Emerald Crest, that's the first question we'll ask is, do they have a history of UTIs? Could they have a UTI? Let's get them checked for that. Let's rule that out first. And anybody that's been around somebody or worked with somebody that has a UTI, you see what happens when they are having the UTI. But then if it's figured out, it's diagnosed, and they're started on an antibiotic, after the week's course of the antibiotic, you see a completely different person once that infection has been resolved. The other thing too to talk about when we're talking dementia, I often get this question asked a lot of times from family members is, well, what's the difference between dementia and Alzheimer's disease? And I think it's kind of important to review that because what I will say, first of all, there really is no difference. When you think of dementia, you got to think of that as an umbrella term. So it's an umbrella term for a decline in their thinking skills, decline in their ability to complete their daily tasks. It's that umbrella term for cognitive loss, memory loss. So under that umbrella term of dementia, there's all kinds of different diagnoses that can cause a person to have dementia. It's just like cancer, if that is easier to kind of follow. You have cancer, and there's all kinds of different types of cancer. There's breast cancer, there's prostate cancer, there's lung cancer. Same thing with dementia. You have dementia, and there's all kinds of different types of dementia. So when somebody asks me what's the difference between dementia and Alzheimer's disease, what I say to that is Alzheimer's disease is just a type of dementia. And it's usually the one that we're most familiar with because you hear about it the most, whether it's through the media, news stories, whatever. It's a type of dementia. These other ones that I have listed here, again, this isn't the complete list of what can cause or diagnoses that cause dementia. It's probably, we have these ones down because it's probably the ones that we see the most. Parkinson's, I'm sure all of you have heard of Parkinson's. That can cause dementia. It can cause cognitive loss. Parkinson's is when basically motor control is affected. You have the shaking, you have the tremors, you have the shuffled gait. All of that can lead to a person having cognitive impairment. Usually you tend to see the cognitive impairment come along a little bit later in the progression of Parkinson's disease, but it is there. I'm going to skip over to stroke, probably a very familiar one that many of you have heard of. That's basically when a blood vessel has burst in the brain and therefore causing a loss of oxygen to that part of the brain. Stroke is a little bit different though. It then affects the functioning of that part of the brain where the stroke occurred. But what's different between a lot of the other dementias is that's why you see people that have had a stroke, they go through a lot of intensive occupational therapy, physical therapy, speech therapy, because the other parts of the brain that have not been impacted by that area where the stroke occurred, a lot of times we can use that area to compensate for the area that was affected. It usually is just that one area, unless they tend to have repeated strokes, which can happen too. The last one on here, Lewy body disease, that might be one that maybe some people aren't as familiar with. The best way to describe that one is, I would say it's a combination of Parkinson's and Alzheimer's disease. So with Lewy body disease, you usually see the typical cognitive loss of cognitive skills like you do with Alzheimer's. Cell death is occurring in the brain, and it just becomes more and more and more as the person progresses. It's also a combination, I would say, of Parkinson's disease. So you kind of have the motor impairment with Lewy body like you do with Parkinson's. You can have the tremors, they become very rigid, hard to move. They have the increase in falls. One of the big telltale signs of Lewy body is hallucinations. A lot of times is what you'll see. Hearing and seeing things, the paranoid thinking, people are stealing my things, people are out to get me. You see a lot of that, the hallucinations and paranoia with somebody with Lewy body. And Lewy body can be really, really tough to care for because a lot of the traditional dementia-specific medications that we may use to take to minimize some of the agitation and anxiety that come with dementia, you can't use a lot of those traditional dementia-specific medications because for whatever reason, it really has a lot of side effects for that person with Lewy body disease. So a lot of times it can be tough. you can try to manage their environment, but a lot of times if you can't use some medications to go along with it, it can be really tough to try to care for that person. So again, just to summarize with this screen, dementia is that umbrella term, and then you have all the different types of dementia under it. This is just another way to look at it. Again, common diagnoses, common causes of dementia. This is looking at it more in a pie graph type picture, where I would say the most we see is probably Alzheimer's, and then vascular is the same thing as stroke, Parkinson's. And with Lewy body, I think we're going to start to see more and more of that, especially with the baby boomers now in that age, that older age group. I think we're going to start to see more and more. And I think doctors are getting better at diagnosing it. It wasn't something I had even heard of when I started in dementia care 18 years ago, not because it wasn't there. I just think a lot of doctors were diagnosing it either just as Parkinson's, because that's what it looked like, or like I said, Alzheimer's. So I think they're getting better at diagnosing it too. The next couple slides here, I think are good. I think they're a real eye opener. It's looking at the brain and what's actually happening to the brain when somebody has dementia. Now, this is an example of somebody after death and upon autopsy had Alzheimer's disease. But look at how different these two brains are. You have on the left side somebody with a normal brain. Look at how much bigger it is. You have a lot of white, healthy matter. Just think about if you ever broke a bone before and you had a cast on. Once you take that cast off after the 6-8 weeks, whatever it is, your limb is almost shrunk. It's a lot smaller. It's atrophied. That's the same thing that's happening with the brain when somebody has dementia or Alzheimer's. It's smaller, and if you'll notice, there's kind of those big gaps, those black areas, the black holes. That's actually where cell death has occurred, and that's what's happening with Alzheimer's disease dementia, is the cells are gradually dying, and it spreads and spreads and spreads. This is just a different way to look at it. This is taking the brain and cutting it down the middle, so it's a cross section. Again, that top picture is the normal functioning brain. Again, much bigger. That white matter is healthy functioning cells of the brain. And then big difference. Look at the Alzheimer's brain. I mean, literally, the brain is gone. There's two big gaping holes, and that's what happens. And then just begin to think, that's the person trying to function day to day. Their brain, the area of decision making, problem solving, all those skills is gone, and more and more of those skills are impacted as the person progresses. Again, another cross section. Again, normal brain on the top, Alzheimer's brain on the bottom. Again, that white matter signifies healthy functioning brain cells. Now, as we go along here, so we've kind of talked about dementia, what are signs and symptoms, what diagnoses might cause dementia. So that person now has went to the doctor and they have actually been diagnosed with dementia. So individuals then are lumped together under the category of having dementia. So then what? So then if somebody is diagnosed with dementia, the next step that really needs to take place is it's then bringing in other healthcare resources, whether that's OT to figure out the stage, or physical therapy, or speech, whatever, social work. It's figuring out, okay, we know they have dementia, but where in their dementia are they? And Sarah, when she starts, she's going to go into more of a detailed staging system, but for right now, I want to look at the stages as early, middle, and late. And it's really important to know if they're in the early, the middle, or the late part of dementia, because that's going to impact what the family needs to consider when planning and providing the right type of care for that person. And so, like I said, we want to look at the person not just having dementia, but let's have a greater focus so that we have more accuracy and success in caring for that person. So let's figure out what stage they're in, okay? And the reason, like I said, why it's important to know is it early, middle, and late, because depending on if somebody's in early stage, what you recommend as a healthcare professional as resources to help that person is going to be very different than, say, if somebody's in the late stages. And here's a list of different resources that we might recommend. It might be, just for, they're in the early stages, you need more education on what to plan for, what to anticipate. So different educational organizations. It might be, you need the support as a caregiver. So what support groups are appropriate depending on what stage your loved one is in? Adult day programs, there's a lot of people that are maybe in the early stages or the very beginning of the middle stages, and they're still doing okay at home with some supplemental help, but they need more structure. They need more engagement throughout the day. So we might recommend, hey, they go to the adult day program, which is basically an activity program, a place where they can go, where they can get more structured activity throughout the day. It's also a very good break for a caregiver if they're still caring for someone at home. So that might be an option. Home companions, maybe somebody doesn't want to go the route right away of admitting them to more of a 24-hour supervised care. So maybe they go with home companions that come in and either do activities with them or provide basic cares, or home care is the same thing. Or it might be to the point where, again, they've progressed far enough, they're not safe to be alone at any time. They need help with the daily cares, and you need more of a memory care facility. So knowing that stage of dementia is key to knowing what resource. And I think this is where I'm going to hand it off to Sarah, where she's going to talk about a more detailed staging or level system for dementia.
Yep, I'll take it away from here. This is Sarah. Yes, I will take it from there. Folks that are diagnosed with dementia, you kind of know what stage they're at. You've been caring for them, helping them along, looking out for them. You know what their basic needs are at that point, but you might want to know a little bit more information. So this is where as OTs, Jenny and I, me specifically right now, are going to bring in these Allen cognitive levels. And most people haven't heard of the Allen cognitive levels. It's an occupational-based theory that is just simply a numerical measurement of a person's cognitive abilities, changes, needs over that period of time of their disease. It's a 6-point scale. So we look at it from 6 being high, 1 being low. There's so many different scales that rate dementia and stage dementia and put dementia into levels. Some are 1 is high, 10 is low, but we are 6 is high, 1 is low, and it helps us as healthcare professionals to guide our recommendations to help families make decisions as to what's best for their loved one. So level 6 is somebody that is independent. As a person progresses through the levels of dementia, they start losing skills. There are still a lot of things they can do, but they are starting to lose skills. And so those are important things to pay attention to. And with particular types of testing for these Allen cognitive levels, healthcare professionals, OTs, neurologists can hone in on these levels a little bit more closely. So what I'm going to do in the next series of slides is talk about each one of these levels and what you need to know about each level as a person concerned about yourself or a person concerned about your loved one. So we'll start with level 6. At cognitive level 6, that is you or I. That is any of us that are participating likely in this presentation. We are independent in our lifestyles. We are independent in what's called IADLs, or instrumental activities of daily living. Those are things like holding a job, maintaining your household, driving a car, using the telephone, managing your medications, managing your finances, going shopping, things like that. We don't need any help with those things. We're independent in caring for ourselves. Our thinking skills are intact. We're able to learn new things. We're capable of abstract thought and planning for the future and things like that. And we can learn new information. Now, as somebody progresses, you're going to see those things change, but I'm going to talk a little bit in each of these levels about interventions we can use at each stage. So really there aren't any interventions per se for level 6 because we're fine. But there are things we can do to help maintain our brains so that our brains are nourished and as healthy as possible to hopefully prevent us getting dementia. There is a lot of research about the brain and diet connection between dementia, developing dementias, and what you put into your body. So these are just some very basic recommendations. If anybody's interested in further information on a brain healthy diet, there is a nationally recognized diet called the Mind Diet. It's a combination of a couple different diets, but these are the highlights. They recommend, the recommendation for brain health is to eat foods that are higher in antioxidants. Antioxidants are little molecules that are in our body, in our brains, that munch up bad things. So like when you have damage to your cells, there's garbage in your brain that needs to be eaten up. So these antioxidants help clean that space up. So foods can put those antioxidants into our body. And you've probably heard that antioxidant-rich foods are often colorful. You may have heard eat the rainbow. The foods listed here are all green, but certainly other foods that are higher in antioxidants are very colorful, other colors than green. So you've got spinach, kale, broccoli, but berries are very high in antioxidants, raspberries, blueberries. Your yellow and green, or I talked about green, yellow and orange and purple foods are also higher in antioxidants. So yellow peppers and citrus fruits and things like that. So those good for you foods are higher in antioxidants. Limiting fatty acids, so limiting the amount of animal fats you put into your body, manufactured fats, trans fats, and things like that. So those are inherently bad for not only your brain cells, but the cells in your body and your arteries. They slow things down in the simplest sense possible. And then another recommendation is eating foods rich in folic acid. That has been found to be an element that is important to brain development. That's even from, many of you mothers would know that that's important for your baby to get folate as they're developing. It helps with brain growth. Limiting alcohol is important too. We know that alcohol is a toxin. Toxins are things that kill cells, so kill brain cells. So limiting alcohol intake, although on the Mind Diet they will say that red wine, high in antioxidants, and a particular antioxidant that is good for brain health. So have that glass of red wine a night. That is a recommendation of that Mind Diet. So please indulge in that. Drink plenty of water. Water is good for the entire body and also the brain to keep things moving. Fruit juices, limit the sugar intake with those, and limit caffeine also is a recommendation for brain health. So treat your body well. Also treat your body well by staying active. Jenny had mentioned that the Delaney sisters said that we got regular exercise, and that helped us to ward off this dementia that people think can increase in old age. So exercise, do something fun. Don't exercise because you have to. Exercise because you want to. Exercise can be going for a walk after supper with your family. Exercise can be playing with your kids in the backyard, throwing a football. My mother-in-law, this maybe isn't fun exercise, but she's at home because she works from home and she can't go to the gym right now. So she walks her stairs 10 times a day because she's at home and she gets a break from work. So, just be creative with that. Keep your body moving. What's good for your whole body is also good for your mind. Learning new things. They say that the more opportunities you take to read a book, learn a new skill, learn a new activity, doing word puzzles, jigsaw puzzles. Those things are all good for helping your brain cells that you do have that are intact keep making connections. We want to keep those connections. Other things like using your non-dominant hand to do activities. Again, we're just looking for ways to keep the brain active. Both sides of that brain, your right side and your left side, do different things. So using non-dominant hands to do things can cross that that divide in your brain. So just doing. Again, that's the key component of occupational therapy. We're human doings, not just human sittings. So keep doing. And then another thing that can help you kind of maintain that health of your brain is just to keep active socially. Again, very difficult right now, but there are ways to socialize still, using the telephone, using virtual means of communicating, trying to go on outings safely, participating in those groups and clubs that you have before. Book club, it might look differently now, but you can still do it. Stay busy. That is actually one of the warning signs of dementia. If you are noticing that your loved one is withdrawing from some of these things, even just family gatherings. Oh no, I don't think I'm going to make it to the 50th anniversary party for my aunt because I just don't want to. A lot of times that withdrawal is a sign of something. So keeping busy is also good for that too. And then looking at the opposite of keeping busy, it is important for your brain health to make sure you are getting enough rest and relaxation to, Jenny pointed out earlier, that normal forgetfulness that we all experience is oftentimes related to stress, fatigue. We're not getting enough rest. So make sure that is something that's made a priority too. Make sure you're getting sleep to replenish your brain and your body. Slow down, try to limit the amount of stress in your life. I think I'm probably preaching for the choir. We all want to do that, but it is worthwhile to figure out how to do that. Even just taking some time to enjoy one of your hobbies, that can be relaxing. That shouldn't be stressful. Some people have found the power of meditation to be very helpful, or just simply spending time alone in your home, in a peaceful place in your home, out in nature, listening to music, anything that brings you peace and calm. Some people really find calm and peace in journaling, getting out a journal and just getting your thoughts out on paper so they're not rattling around in your head and causing some of that stress that you may feel. So those are just some things to help you keep on keeping on at that healthy place you're at, to try and ward off those signs of dementia. So all of that being said, you're all good until you start noticing changes in yourself or somebody else. And so these subtle changes that I'm going to talk about here are often seen at what we call Allen's cognitive level 5. You may have heard the term mild cognitive impairment. That is simultaneous with our cognitive level 5 that we're talking about here. Or in other words, that's early stage dementia. Again, Jenny talked a little bit about some of these earlier signs. People that are at a cognitive level 5 that are considered in that earlier stage of dementia are still capable of doing their daily cares. A lot of times people, even if they have a dementia diagnosis and are still in that early stage, these familiar processes, folks do fine at this cognitive level with their cares. They're still aware of the fact that I have to get dressed every day. They like to look nice, that kind of thing, aware of that. Subtle problems in memory are noted, just in conversation and in passing, you might notice, when I was talking to her on the phone, she told me that story last time and she just told it to me again. I'm going to listen when I talk to her in my phone call next week. Does mom tell me the same story over and over again? So subtle changes, occasionally forgetting things that they might not have, performing, a familiar recipe, maybe one that they never had to dig out the recipe card for. They've been making it for 35 years. And now they're like, oh, shoot, I forgot an ingredient. So just subtle things change. Also at level 5, you might start to see these other changes that Jenny also mentioned a little bit earlier. things that might not be as apparent on the surface, but changes in what I talked about before, those instrumental activities of daily living, specifically finances. Perhaps not keeping up with the bills like they used to. Things are getting forgotten. Driving skills. A lot of times with folks at level 5, they're still driving and they're doing fine. People with dementia in the early stage can drive, but you're going to see those folks probably putting restrictions on themselves. They might start shying away from driving at night or taking the highways. And those are really, what I would consider coping strategies. These folks know that something's wrong and they're trying to continue on with life as normally as possible. Other things related to the IADLs is you just might see somebody, like Jenny had mentioned earlier as well, further disorganization in their household, in maintaining like organization of their finances, of plans that they've made and things like that, or be making poor decisions that they would not have normally made in the past. The good news about a cognitive level 5, somebody at that cognitive level 5, is that they can learn new information. So so you can still have these conversations about the future and plan for things. And that's kind of what we'll talk about next year when I talk about the interventions at cognitive level 5 on the next slide. When somebody's in that early stage of dementia, that level 5, oftentimes they are still capable of living on their own, but just might need a little bit more assistance from family members, from a neighbor, just with more check-ins, utilizing possibly community resources, maybe having meals delivered, things like that. Talked about when we were on the last slide still, that it is still okay. I mean, it is a good time actually to plan for the future and talk about, that person's wishes. So should, we head down this path of dementia, they lose more of their abilities, more of their decision-making skills, what do you want? Things like, planning those healthcare directives, planning for what kind of care you would like if something catastrophic happens, that kind of thing. Somebody at a level 5 can still participate in that conversation. Mentioned that people at level 5s do have challenges with those instrumental activities of daily living skills. They're managing their finances, driving, medication management, and their nutrition. So a lot of times people at this stage just need somebody to check in on them. This might be where you would, if it's your mom or dad, you might want to get a joint checking account with them. You might want to take them for a driver's evaluation because family members have gotten into quite a few rifts with loved ones about trying to manage their driving habits. And so if you can get an appointment set up with a driver facility, or there are, the VA Medical Center does driving evaluations. It's a service they offer. Having somebody else tell mom or dad that their driving skills might be changing is a lot easier coming from somebody that's not directly related to them. Family members might need to manage medications. You might need to use a pill box setup sort of thing. Or utilizing a phone call to say, Mom, take your pills, they're on the counter by the sink. You take this one at this time. Making that phone call can sometimes be helpful. Preparing meals with that person, and then having them in the fridge and they can just reheat things versus having them have to use the stove, because that's where we start to see challenges start to arise in this early stage of dementia. There's ways to modify the environment. I'm speaking more from a safety perspective. Somebody that is in that early stage of dementia at a level 5 may not be as aware of, what's safe, what's not. They might think it's perfectly fine to step up on that swivel chair and try and change the light bulb. So maybe try and modify the environment to make sure that it's safer. Maybe you remove some of those things that you might think ahead and think they might use, or just trip hazards too. Falls risk. Anybody can be a falls risk, but certainly people with early stage dementia, they don't often foresee dangers like that. other coping techniques we can put in place for people at a cognitive level 5. I talked about the medication box, utilizing calendars, writing things down. I sometimes worry that I have dementia because I use calendars and lists all the time. But these are coping strategies for folks at that level 5 in the early stage of dementia. It's just having everything in writing because they still can read and comprehend that kind of thing. And then just knowing that things may take longer for that person, they still can do them though. So, just allowing as much independence as possible while still monitoring some of those things to make sure they're safe. So level 6, independent. Level 5, needing a little bit supervision from somebody. So we're going to talk next about level 4. And level 4, if we're talking about those stages that Jenny introduced, we're now into the middle stage of dementia. And typically you'll hear of level 4, if you hear more talk of the Allen's cognitive levels, of this middle stage or level 4 Allen cognitive level being a transitional stage, being kind of that point where the person may not really be safe in their own home any longer and may be needing more intervention from somebody somehow. Typically, folks at a level 4 are independent with caring for themselves. Again, a lot of these tasks, these rote tasks that we learn as we are developing, as from children on, stick with us. We still know how to put on a pair of pants, and we pick up our toothbrush and we instinctively know how to do that. And that is a level 4. They still know how to do those things, but they're forgetting. So they might need help to initiate doing that care. So a phone call to say, make sure you get dressed. You may have been over there earlier and laid out clothing for them. That is a visual cue. We recommend at a level 4, and we'll get to this here in the next slide, but using a lot of cues to help people be successful. Using a lot of visual cues and reminders for that after you've helped initiate them with their task. Level 4, you are going to really start to notice the memory impairment here. You might have noticed some subtle hiccups in level 5 when they're in that early stage of dementia, but the memory impairment is more noticeable at a cognitive level 4. You are going to hear the same questions over and over again. Not over and over again within minutes, but you are going to hear that on a day-to-day basis. The same thing yesterday is said today. So that is a big difference. Folks at a level 4 don't retain information like we would at a level 6, or even at like a level 5 would. You have to repeat things quite a bit. And so when I'm training our caregivers, especially that are working with our residents, I always tell them that you're going to have to repeat yourself. Please don't get frustrated with repeating yourself. And please also at a level 4, remember not to say, don't you remember I told you that already? Or don't forget your walker. They are going to. And so just having a little patience with that too is important. At this cognitive level, at level 4, like I said, because it's transitional, if they're closer to a level 5, they're probably still doing okay with some checks at home. But as they move further along in level 4, they're going to start to lose more skills to the point where they're going to need continuous supervision. So that 24-hour supervision to make sure that they're safe and they're safely doing things in their home. So the next slide, we'll just talk about some of the interventions that we often will recommend when somebody's very much into that middle stage of dementia at that cognitive level 4. Certainly, there's still some community resources. I mean, you can, there's the option of home care coming in a few times a week for somebody that doesn't need as much help. But there is the option of having home care there every day. So if that is a financial option for your situation, that is out there. Other community resources as far as, activity and meal-related services are also out there too, to be supportive to family members. Folks at that middle stage at a level 4 are going to need daily monitoring. So if that is somebody that's still living in the community, they will likely need somebody living with them. But this might be the point where families do start thinking, I don't know if we can help them in their home still. I don't know if we can make it work to have them come live with me. You're starting to look at places that can provide that supervision throughout the day and provide care services throughout the day as well. Folks at a level 4 are going to need help in all areas: initiation of dressing, help with their medications, making sure they eat square meals. Somebody's going to need to transport them to, store, appointment, that kind of thing. One of our other tricks of the trade here is setting things up so that they're visible. Folks at this level, at a cognitive level 4, if they see things, that often triggers them to do something with that thing that they see. So if you set out a person's clothing the night before, for when they wake up in the morning, they will likely get up, see that laying over the chair or laying on the bed or wherever you leave it, and say, oh, I have to change into that outfit. Leaving, food set out on the counter is a visual cue. Leaving their grooming supplies, exactly what they need to use, out is a visual cue that's going to help people notice what needs to be done versus having to be told what to do. They can just see it and do it on their own. Talked about earlier that your patience is key. As somebody is getting into this level, you are going to have to repeat yourself to help them throughout their daily routines. And we talked about modifying the environment at a level 5 for safety. Modifying the environment at level 4 is still all of those things for safety, but looking at things a little bit differently too. Maybe going as far as having them sit down for showers, putting a bath bench in there, having less stuff in their environment. We call that downsizing. Sometimes what we see a lot with our folks at level 4s is the more stuff they have, the more confused they actually are because they don't know what to do with it all. And the more stuff you have, the more easily things can get misplaced. And we know from ourselves, we are forgetful. We do misplace things. If somebody has dementia and they're misplacing things, they are not going to be able to retrace their steps and find things because things are going to end up in really strange spots. And so the less stuff there is for things to get lost in is a lot easier. So we do recommend downsizing at that level. Level 4 is that transition where they may be doing okay in their home, but now we're looking at somebody that's struggling even more. And if you are a caregiver of somebody at home, you are likely struggling even more to help them, to get them to understand you, because at cognitive level 3, which is what we'll talk about more, this heart of the middle stage of dementia, this person does need help with all of their daily cares. Their mind is more jumbled than it was before. Their memory is very poor. If you think back to that cognitive wheel that Jenny talked about earlier, so many things are going haywire. They're not just forgetful. They don't know how to initiate things. They don't know the right order to do things, and they might not recognize objects anymore and how to use everything appropriately. They might be doing well with some, but may forget what some things are, and so that can be quite overwhelming for a person at this level. So you as a caregiver or whoever is caring for this person at level 3 is going to need to be there with them all the time to guide them through their day and give step-by-step direction. We're going to talk about that in the next slide. And the other key piece of a level 3. Level 4, a lot of times verbally people are kind of holding their own in conversation. They're able to cover some of their deficits with jokes and whatnot, and still kind of have a store of things that they usually talked about. At a level 3, you are going to see a more significant change in what that person is saying. They're going to be repeating themselves regularly, asking the same questions over and over again. They are going to be forgetting more and more words than they have been before. All of us grasp at words sometimes. We're like, oh, it's on the tip of my tongue. But these folks will say things that sometimes don't make sense to us. And so we have to, dig a little bit deeper to kind of figure out what they're saying. So, so you're going to see a big change in language skills. So we'll move on to the next slide and talk about what you can do to help somebody at this level 3. All of those things that I said before, the person will need 24-hour care. A lot of times families are willing to go that distance with them in their home, but this is often the time where something's got to give, and you see that person in a facility getting more of that 24-hour care by additional care partners. And the nice part about the middle stage here is that it's a little bit easier to partner with that person because they're not upset about getting the help. At level 3, a lot of the folks that we work with are at that level. You tell them what to do, and they often will do that. The caregiver is there to kind of fill in the gaps for what they can't do. It's giving step-by-step direction. It's handing them one item at a time, telling them what to do with it, and just kind of slowly making your way through care, making your way through the day, giving them their food and saying, go ahead and try a bite, let them eat, and then create a structure for them. And that's what I'm going to talk about kind of moving forward here, is how we can help them along, fill those gaps, create that structure. So we'll take a look at the next slide here. And this is just kind of a visual or pictorial way of how we intervene a little bit differently in different ways. So the first visual is an example of how what we do at level 3, especially with our folks at level 3, is simplify their lives. And so at meal times, this first image is a way of simplifying what a person's meal setup looks like in front of them. You see the picture on the left there is a full meal setup, plate, utensils, napkin, couple drinks. That can be really overwhelming for somebody at level 3. That can be too much stuff to focus on, to concentrate on. And so a lot of times we'll see people at that level just kind of shut down. They don't even initiate eating. They won't take a drink because they're just so overwhelmed by, what do I do with all this stuff? So we will simplify what we serve that person. We will have their meal served on one plate, put out one utensil, and put out one glass of a beverage to help them focus a little bit better. And certainly we can simplify that even further if we do need to, but simplification is kind of the name of the game in this middle stage, or cognitive level 3, as we're in the heart of the middle stage. The middle image there is just a sequence of how we as caregivers, as loved ones of somebody that has dementia, can simplify how we're interacting with them, how we're communicating with them. Verbal communication is such a big part of how we interact with people, that when it's your loved one that you have to change how you interact with, that's hard, because that's somebody you may have had lengthy conversations about with in the past, and now they can't do that anymore. So you're going to have to simplify, using shorter sentences, breaking things down one step at a time, only saying one thing until you know that person understands it. You will see as we get further along into these Allen cognitive levels, we are going to simplify even further to one-word directions, physically helping a person, showing them gestures and things like that. But for our purposes, our folks at that level 3, we're using a lot of step-by-step directions to simplify our conversation and our communication with them. And then the last visual there on the bottom row is just a way to simplify activities. Now, this is just one specific example of simplifying activity for somebody that perhaps likes doing jigsaw puzzles. Somebody that's a level 6, 5, or even 4 could probably do a more normal looking jigsaw puzzle. As that person moves into the 3s, that's maybe still a meaningful activity for them. But the multiple pieces, the visual ability to match up, so those colors that are so closely related, is harder. And so you will want to find smaller sized puzzles that have less pieces. So not smaller size so they can't see it, but smaller number of pieces. So, if they were regularly doing 500, 750 piece puzzles, you might need to downgrade to a 160 or even 25 piece puzzle as they progress through that level 3 of that middle stage of dementia. The following two pictures that are on the right there would be more for folks that are in the levels that we'll be talking about in the next several slides. So those are just some interventions related to meals, communication, and activity for those level 3 folks. So we'll take a look at the next slide. Again, just another visual for me to give you all some ideas on how to modify spaces to simplify. You know, I talked about an intervention being downsizing because people get overwhelmed by too much stuff and they are not using things that the way that they should. They're forgetting what things are. And so if you take a look at these two photos, take a look at the picture on the left. That picture shows a bathroom sink counter that has a lot of stuff on it. Not uncommon for bathrooms, but for somebody with dementia, there could be a lot of mistakes being made there, especially in the middle stage of dementia. So you've got a couple things that one a very evident cup, one thing that looks kind of like a cup, things that look like liquids. One is a water bottle, one though is liquid hairspray. Though that could be very easily poured into a cup and drank. I have worked with worked with folks that I've gone to their room and they were in the bathroom already, and one gentleman, I said, "Good morning, sir, how are you?" He turns around and he's got a face covered with sticky blue gel. He had used toothpaste on his face instead of shaving cream. So he had the right idea, but he didn't have the right product because there were a lot of products on his counter that particular morning. So what we recommend is, again, simplifying their space. So keeping that counter clear of all products, really. And then you as a caregiver, when you go to do cares with them, lay out exactly only the items they will need to use during that particular care. So simple is better. That is a mantra we live by in memory care. It's just keeping things simple for that person. So one of the other things that we can simplify for our folks that are sitting at that middle stage of dementia, that are in that cognitive level 3, to make their day easier, is to structure their day. You know, we talked about people losing all sorts of skills, the skill to initiate, sequence, plan, so get through their day, do things, a schedule of things for their day. You know, we all have our to-do lists, our regular routines during a day. Somebody with dementia, those routines get smashed to smithereens because their brain just can't process that anymore. So so what we find is very important for our residents at Emerald Crest, and we also recommended this to families that are still, you know, living with their loved one at home. Try to create some sort of schedule to your day. Get up in the morning at the same time every day. Have breakfast at the same time. Have scheduled, you know, have the shower days, or, you know, the shower evenings scheduled into your day so that they become routine for that person. You know, if you're in your own home with them still, maybe, you know, after breakfast in the morning, you both read the paper together, watch a TV show together. Then you go for a walk around the block, weather permitting, and then you have lunch, and then maybe you have a couple different activities planned after lunch. A drive in the car, you go run errands together, but have it be structured and the same throughout the day. That's just going to help the person with dementia and also you as the caregiver. That is what we find works best in our setting, working with people that all have dementia. Huge recommendation is just providing that routine and structure for somebody at that cognitive level 3.
Sarah, can I interrupt just real quickly?
Sure
Can you just explain the importance of time to rest as well for individuals throughout the day?
Yep, absolutely. So thank you for reminding me of that, Christine. While it's important for folks to keep busy, it's also important for folks, especially that are in that middle stage of dementia, to get some rest during their day to kind of recharge that battery. Just giving them a break from all of that activity, because a lot like one of the things that Jenny and I will use to educate our caregivers on with these Allen cognitive levels is it's almost like developing in reverse. So when your children, grandchildren are growing up, and when they're 3, 4, 5, 6 years old, you know, they get to a point in their day where they're tired and they throw that temper tantrum. While our residents with dementia, our loved ones that are in the middle stage of dementia are not children, they don't know how to take a break themselves. So we have to structure a rest into their day. And so what we do at Emerald Crest is structure a rest time after our group of activity. So say you get up in the morning, you have breakfast, you do some activities, take a break, have some lunch, do some activities, take a break, have dinner, do some activities, then it's bedtime. So rest is crucial to add to that structure that you have for their day. Helpful, Christine? So that being said, we know that folks at a level 3, they have lost a lot of skills. There's still a lot they can do. We talk about keeping busy and allowing them to do as much as they can. As somebody loses more skills and moves into that late stage of dementia, late stage is considered these Allen cognitive levels 2 and 1, which I'll talk about here in the next couple slides. Level 2 are folks, when you see somebody in the late stage of dementia, they are less aware of the environment around them, dependent in all of their cares, but still can assist. So what I mean by that is you may have to do most of the work for that person. You may have to get their shirt started, but they can move their arms to help get it on the rest of the way, or they can kind of help pull it down a little bit more. Or if you get a sock started, they can pull that up a little bit. But again, they can move limbs and help out with that. They may still kind of feel and understand that routine that you're helping them with. There is a significant impairment of all their cognitive skills. Their language skills are very much diminished at a level 2. We talked about folks at a level 3 really not being able to find their words, saying things that don't often make sense together. Level 2's language skills are a lot more garbled. When they speak, it's not often very clear. They may use less words than they used to. We have had our fair share of residents that are in that late stage of dementia, but they're still capable of saying hello or hi or thank you or putting a couple 3 words together in a sentence. You just have to be patient in waiting to hear some of those words come across. And I think that's probably one of the more challenging things for loved ones as the person with dementia declines, is they lose their language skills, and you've relied so much on talking to them that now it feels like there's a loss of what to do because those words don't matter as much. But still talk to that person at that level. Just know that you may not get as much of a response. Level 2 folks, you see a really big change in their motor skills. A lot of times folks are still, moving around, walking, doing fine at a level 3. At a level 2, they might start slowing down a little bit. You might see them sitting more. You might see them leaning to the side when they're walking or sitting. That is not a physical problem. That's a brain problem. That's the brain not communicating with the body, how to control their posture, telling them where they are in space anymore. So there's a lot more things happening in the brain that used to be automatic that are no longer automatic. And so you will see more leaning, you will see slowing down, you will see shuffling gait, smaller steps, leaning forward. You might see people falling more at this level too, just again, because that body isn't communicating with the muscles and the joints on how to kind of maintain posture or, keep that balance quite on the straight and narrow. Visual perceptual skills are something that changes throughout the course of dementia, but becomes even more apparent in these late stages of dementia. People start to lose their peripheral vision. So they're aware of less and less around them unless it's right in front of them. So one of the recommendations that I believe is on the next slide that we'll talk about, is that it's very important to make eye contact and approach people, especially in the late stage of dementia, from the front, so that they know where that voice is coming from, who's talking to them. They feel more safe and secure. Again, that being said, you should always approach and make eye contact with people with dementia, no matter what stage there are. This next bullet point points again to something that is very challenging for families, I think, is that folks in the later stage at this level 2 are not recognizing familiar faces any longer. This is where you might start to see your dad not recognize you as his daughter. He might mistake you for somebody else or not recognize you at all. But the next day when you come visit, or that you're there, that you're helping him, he might recognize you. And so it's just the connections in the brain are very, 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 very spotty at this cognitive level. The recognition also goes for objects too. As people move out of the level 3 into the level 2, one of the big key indicators that somebody is moving from the middle to the late stage is that they're not using objects like they used to. The biggest place you can identify that is at meal times, not using utensils appropriately. You might see people as they're nearing the end of that level 3 start using their fingers to eat, because the fork's there, they just don't remember how to use it. So that's one of my key examples of not recognizing those objects like they used to. And certainly, like we said, with level 2 or level 3, this person will require 24-hour supervision. So we'll just talk briefly here about some of the interventions that you can use with your loved one at this level, because there has been that loss of verbal skills. There might be quite a few physical changes that limit the amount of physical activity that you can do with that person. We tend to focus more on sensory-based activities. So listening to music, moving to the music. We utilize a lot of music in our care at Emerald Crest. A lot of that music hits a part of the brain that is preserved from the decline that people often will feel with dementia, that they'll experience with dementia. So music sticks, and so we utilize a lot of music. So recommend that, especially those things from when they were a young adult. Those songs are the ones that usually stick the best. We utilize, again, just keeping up with the senses, you utilize the sense of touch, move away from conversation and more to just sitting with your loved one, holding their hand, giving a back rub. A hand massage is shown in the picture on the slide here. That sense of touch can be perceived as very loving, but also as very calming. And that is a big part of what somebody in the late stage of dementia needs is that sense of calm, comfort, and relaxation. Another sense that we can tap into is the sense of smell. Utilizing essential oils or familiar smells. We've asked families to bring in flowers to their loved one's room, especially if we know that they used to love being out in the garden in the spring and the summertime. But also utilizing essential oils to create a fragrance, for one thing, but also fragrances can also have different effects on a person's emotion or alertness. So we will use lavender oil oftentimes because it has calming, stress relieving properties for some people. So diffusing that, using that as a room spray mixed with water can create a sense of calm. Using peppermint oil, I'm just throwing a couple out there that are most commonly used, can be very alerting. Citrus oils can be alerting. Other things that can be calming if diffused, cedarwood oil, chamomile can be relaxing. So those are just a few fragrance interventions that we can use. So focusing on the senses is an important intervention at that late stage. And then we'll kind of wrap up our cognitive levels by talking about Allen Cognitive Level 1. This would be considered that end stage of dementia. when we're examining a resident or testing them or assessing them for what cognitive level they're at, what stage of dementia they're at a level 1, we don't see residents spending very much time at this cognitive level. At this level, they are totally dependent in care. And level 2, I said, you'll have a little bit of participation by moving limbs, holding on to things, but we are really doing all of the work as the caregiver at that end stage of dementia. A lot of times folks in the end stage at cognitive level 1 have difficulty and discomfort sitting up. So spend more time in bed than out in the common area than sitting up in a chair. And they have very limited social interactions. As we've progressed through these cognitive levels, a person's world has become a lot smaller. And while a person in the late and now end stages of dementia may not look like they're totally taking everything in, and they keep their eyes shut more often, they still are sensing things around them, but you're going to see a lot more limitations in eyes open, social interactions at this level 1. So, but still let that person know that you're there with them. At that end stage of dementia, the interventions that we have at our fingertips, the resources that we have available are those hospice care services. So I always, when I'm presenting, I always tell people that hospice is a good thing. I think in my experience, a lot of families will prickle at the suggestion of hospice or become very scared because hospice, I think, has gotten that stigma of that person's going to be passing very, very, very soon. And that's not the case. At that end stage of dementia, we know that they don't have much longer, but we want to make that time that they do have left as comfortable as possible. And that is a support to the person that is passing, to bring things that are more comforting into them, to bring things like extra care, music therapy, spiritual care, pet therapy, massage therapy, to just bring that comfort to them as they're living their final, months on earth here. But hospice and comfort care is also a support to family that is also has been and still is going through this journey. We are oftentimes as the caregiver, the one that's more aware of the end being near. So hospice and the care we provide at the end stages is about the entire family and not just the resident. So, but it is about comfort. So that was a synopsis of all of the Allen's cognitive levels. And then prior to that, just kind of what dementia is. So we thank you all for attending our Zoom presentation. To conclude, you've all started your learning process here, whether you're new to this or not, by becoming educated. If you are worried about yourself or a loved one, like Jenny talked quite a bit about, seek that evaluation of a medical professional to help get you started and to help guide you on the beginning path of your journey here. Make sure you're reaching out for support, utilizing those resources of support groups, other family members, people who have been through this before, utilizing community resources, whatever they may be, and whatever you're comfortable using, and continue to maintain your brain so that you can live life to the fullest here.
Great.
And then I think Christine was kind of monitoring chat for questions. So now is a good time, if you've got those questions, to type those into that chat button on the bottom of your screen.
Yes, thank you so much. At this point, I don't see any, so we'll just wait for a minute or two here and see if anybody has any questions. But thank you very much, Sarah and Jenny. I've probably heard your presentation over 100 times, and I always learn something new every time. So thank you very much. It's always great information. And as I mentioned at the beginning of this, we will have the actual handouts and a recording of this available probably sometime next week. And then the CEU will come with that as well for those that are healthcare professionals that need that. If for some reason you do not receive that, feel free to email me. My information is also, I believe, in the invite that you got for the Zoom link. So we have our next session is next week. It's on Wednesday, November 11th at 2 p.m. And we're going to just take it another step here, a little bit deeper into communication for caregivers and the individual with dementia, taking, again, what we've learned today, but putting it into more practical communication techniques. So if you haven't signed up for that and you're interested, please do so. Otherwise, if you have already, you're set to go, and we'll send you that link again before next Wednesday as well. I still don't have any questions, so gonna give you all a couple more seconds here, but it looks like you guys must have did a good job, and there's no questions. So any last remarks, Sarah or Jenny?
I don't think so.
Okay.
No,
Well,
just a big thank you.
yes, thank you everyone, and we look forward to next week. So have a great rest of the day.